Okay, everyone. Can we start now the next session over this morning with the moderator, Dr. Vidayashri and me. We move on to a very exciting and useful topic for all neurologists. How to approach, how to diagnose, and to manage Parkinson's disease. And with my friend, the very well-known specialist on PD of Thailand and international too. You are international. I think this topic will be very useful for us, and particularly with the help and the knowledge of Vidayashri, Dr. Vidayashri. Thank you. Dr. Our speaker is now Dr. Lim Tien Tien from Malaysia. How to examine patient with Parkinsonism. Please, Dr. Lim.
Thank you, Mr. Chairperson. I'd like to take this opportunity to thank Prof. Rong Ruch, Dr. Jirada, and of course, Dr. Tai for this very kind invitation to this Indo-China conference. I also like to thank the organizers for such a warm welcome. And I'm very happy that I had fur and good coffee yesterday with Dr. Tai. So I'm going to start the next talk on how to examine patients with Parkinsonism. I'm a neurologist from Penang, Malaysia, with a specialization in Parkinson's and movement disorders. So, as you heard from the previous speaker on the phenomenology, the approach to examine patients with Parkinsonism, generally, I would divide them into three categories. The first is during the examination, and I'm mainly talking on the physical examination, not about the history taking, to determine Parkinsonism. The second would be to look for red flags, or what we'll say as atypical signs in Parkinsonism. And the third is watch out for mimickers, things that look like Parkinsonism, but it's not. So in order to determine Parkinsonism, the four cardinal features, the bradykinesia should be have to be there, stiffness, the rigidity, the typical rest tremor, and postural instability. Look out for this, and you normally need at least 2 out of 4 of this to diagnose a patient with Parkinson's disease, but we'll talk about those atypical ones later. And we have things like flex posture and also freezing of gait. Next, we then look at the red flags, which are things like early gait instability and falls, which normally do not occur in patients with Parkinson's disease. Absence of tremor, that should ring a bell to say whether it is really those akinetic rigid type of Parkinson's disease, or it's those atypical Parkinsonism. Careful with the eye movements. In the early stages, it may be very subtle. For example, like the saccade, the slowing of the vertical saccade in patients with progressive supranuclear palsy. Cerebellar abnormalities, autonomic dysfunction. And look at their posture of the patient, whether there's any disproportionate anticolis or any contractures, stridor or size, dysphagia, axial signs like dysphonia, dysarthria, and also check for those cortical sensory signs, apraxia, looking out for myoclonic jerks and early dementia. The mimickers, I won't be talking in this lecture because I think it's a topic on its own and it's going to be long. So, but just watch out for things like essential tremor that you have seen in Dr. Jirada's lecture just now. Pyramidal tract lesions, depression, hypothyroidism, and psychogenic Parkinsonism. So this is a patient that I saw early this week. And I think this everyone will know is a very typical patient with Parkinson's disease who walks into the clinic, you see the faces, you see the posture, you see the typical rest tremor, and you know that this patient has Parkinson's disease. And you're quite happy that you make a diagnosis there and there as the patient walks in. But there is a very interesting article that was published in 2018 in Practical Neurology, where it mentioned that maybe even before the patient walks in, we could have idea of what the patient may be having or what the diagnosis is at the waiting room. And sometimes as we go into the hospital, we see patients walking into the main entrance or walking along the corridor, and you may think, hey, is this my patient that is coming in? And you look at the behavior of the patient, we look at the sitting posture of the patient, and we look at even the clothing and the accessories of the patient. And this is an article that is worthwhile going through and reading it. I just point out a few of the points here. For example, if you see a patient with bruises, injuries over the face, and you may think that this is early or marked postural instability in a patient with atypical Parkinson or progressive supranuclear palsy. If you see a patient just diagnosed recently, or you have just diagnosed it and the symptoms occurred like maybe a year ago, and is on a wheelchair by now, and he has features of Parkinsonism, perhaps we are dealing with atypical Parkinsonism with early falls and postural instability. If you see a patient who is dozing off in front of your clinic, watch out. Is it because we have given the patient dopamine agonist that is too high of a dose, any sedative medications because previously patient could not sleep, or yet a patient had a poor nighttime sleep quality? So these are the examples of what we look at in a patient with Parkinsonism. Restlessness, dyskinesia, whether we are dealing with akathisia, drug-induced Parkinsonism, or dyskinesias. Okay, so to determine Parkinsonism, as I've mentioned in the first slide, the first four: bradykinesia, rigidity, tremor at rest, and loss of postural reflexes, plus the freezing motor blocks and also the flex posture. We normally use the 2008 Movement Disorder Society Unified Parkinson Disease Rating Scale, and the motor part is the part 3 motor examination. If you can see from this scale, the ones in the red box is the part 3, and it focuses on the speech, the facial expression, rigidity, bradykinesia, gait stability, and tremors, which what I have mentioned just now, except in a more detailed manner and in a way to scale it so that it becomes more objective. As you know, we do not have a real biomarker in a patient who has Parkinson's disease. So I'm just going to show you an example of this video, but this video is not a full video of the examination. I had to cut it short because of time consumption. So for example, if you see the eye movement examination, it shouldn't be that simple. You should actually carefully examine the saccades, examine the pursuits. But you can see that this patient has the typical right hand resting tremor. And you would want them to count backwards, maybe say the months of the years backwards from December to January. If the sound can be on. Then you look at the tremor at posture and just wait a few seconds to see for re-emergent tremor. Look for bradykinesia with finger taps, hand grips, pronation and supination. And then check the lower limbs, the foot tapping as well. And always compare both sides, the right side and the left side. Typically in Parkinson's disease, one side should be more severe than the other side. And the most important one, the gait examination. Look at the posture, look at the stride length, look at the arm swing. Look at how the patient walks. Then the pull test. We'll always warn the patient before doing this test and tell them that they should take large steps backwards and at the maximum 2 steps backwards. And make sure that something is behind you so that you don't fall together with the patient. look for cerebellar signs, measure the blood pressure, supine and at the erect standing position. So just a few highlights. I won't go through the whole Unified Parkinson Disease Rating Scale. For example, in facial hypomimia, you look for the mask-like faces and whether the lips are parted sometimes when the mouth is at rest, and that would be a category of mild, which is 2, and moderate. You can see this patient with associated dermatological seborrhea, if Parkinson patients, decreased eye blinking, masked faces present in the lower face as well, namely fewer movements around the mouth, such as less spontaneous smiling, but the lips are not parted, so this becomes a 3. So sometimes the faces can tell us more than whether it's Parkinson's disease or a normal patient, but it can also tell us that there are maybe features of atypical Parkinsonism, and they don't look the same. So if you can see A, so this is from PRDs in 2019, a patient with mask-like faces in Parkinson's disease. But if you see B, it's actually a different faces of patient with progressive supranuclear palsy. You can see the vertical muscle, the corrugators, and the procedural sign. And in C, you see a reptilian stare in a patient with PSP. D is a patient with blepharospasm. So you can see the bit of contraction around the orbicularis. And E, a patient with apraxia of eyelid opening. And F, orofacial dystonia in a patient with MSA. So in bradykinesia, we not only look at finger tapping, we look at the other features as a whole in a patient as the patient enters the clinic, and as the patient, and we examine the patient. We look for decreased facial expression, slowness is movement, as you can see in this patient. And we look at the small handwriting. So you can see as this patient, he has not only slowness in writing, but the tremor comes in when she writes. This is the finger tapping. Should be done in all patients with Parkinsonism. And hand grip movements. And the soft monotonous speech. Perhaps very soft until you can't hear it now. Okay. There is an article from the brain that says that there's one feature that may be useful sometimes where when you check for the finger tapping, you look for also decrement, means that in patients with Parkinson's disease, you may notice that in the initial part of the examination, the amplitude may be quite wide, but as it goes, after a few seconds, it becomes smaller and smaller. But in patients with atypical Parkinsonism, for example, in PSP, they may not have the decrement because it starts slow from the beginning. So it's slow all the way, as opposed to this one, where you can see that it's quite big and then it becomes very small, although it may be fast in frequency. Similar for the handwriting, in PSP, they may be already small handwriting and they write throughout the sentence, it's small. Whereas if you can see in a patient with Parkinson's disease, sometimes it's quite normal at the beginning, and as you write more, it becomes smaller and smaller. Another thing not to be missed is the rigidity, and I just highlight one point that when we check for rigidity, remember sometimes the rigidity when they come in is quite mild. So you may need to do it with activation maneuver. Perhaps the other arm, ask them to do something, some pronation, supination, or hand grips, and then recheck the rigidity. So if it's so slight, you may actually, with activation maneuver, then it's actually classified as 1 in the UPDRS score. Okay, next we come to tremor, and this is a consensus statement of the classification of tremor from the Task Force on Tremor in the International Parkinson's and Movement Disorder Society. And we look at tremor characteristics, meaning that we look at the body distribution. And in Parkinson's disease, normally the upper limb predominant, you get tremor, which is asymmetrical, was on one side, resting 4 to 6 hertz type of tremor. And then you do activation conditions and look at the tremor frequency. And in Parkinson's disease, the tremor frequency is not as high normally as the tremor frequency in essential tremor. So for the activations of tremor, you look at whether it's rest and action, and whether it's kinetic, postural, or isometric tremor. So you get used to this tremor in the patients with Parkinson's disease. Relatively high amplitude in this patient, low frequency at rest. And as the patient counts backwards, or as the patient says the months of the years backwards, you can see that the tremor increases. And then when he lifts it up, the tremor almost disappears. Okay. Sometimes you see patients, a lot of times, people refer, other consultants may refer as a tremor, but if you look carefully, they may not all be a tremor. And I just show you these two cases where they are very jerky, smaller amplitude compared to the ones you saw, but you see that jerky component in these two patients.
Oh, okay.
So you want to call it jerky tremor, or you want to call it myoclonus. But this is more common in patients with multiple system atrophy. And if they have predominant Parkinsonism, MSAP, which happens in up to about almost 50%, as compared to Parkinson's disease, which is only about 6% from the study. So the pill rolling tremor in Parkinson's disease is actually rare in MSA. The tremor, or so-called tremor in MSA, is often higher frequency, lower amplitude, sometimes jerky, maybe stimulus sensitive, and has a myoclonic component. So we sometimes call it as a mini polymyoclonus. Another thing about tremor, that when we examine the tremor and as we ask the patient to lift up, don't do it too fast, just wait for a few seconds. And sometimes you get a tremor frequency which is almost equal to a resting tremor of a Parkinson's disease patient. And we call it a re-emergent tremor. So this is about 3 to 5 hertz, like what the resting tremor is. And it may have a relatively good response to dopaminergic therapy. So you can see in this video, you do see the resting tremor here.
Good. Can you hold your hands straight out for me? Yeah.
No tremor. And then after a while, the tremor comes up. And the frequency is almost the same like the resting tremor. So this is a re-emergent tremor. Next, we go to the fourth one, which is posture. So posture in a patient, we know the typical stoop posture in Parkinson's disease. But if you have a patient with anticolis or retrocolis, always think again. And in this patient on the left, anticolis has an MSA and a retrocolic in PSP. Other abnormal posture would include things like camptocomia and PISA syndrome. So camptocomia is a marked flexion, normally more than 45 degrees at the thoracolumbar spine. And when the patient lies flat supine, it goes away. So the posture becomes almost normal when she lies flat. And this occurs in about 26% in MSA, which is more common than PSP and Parkinson's disease. In PISA syndrome, you have a lateral flexion of about 10 degrees or more of the spine, and also abates when at a recumbent position. And also it's more common in MSA. This is just to show you again, loss of postural reflex and the pull test that you have seen before this. So be careful, like if the wall was not behind me, I may actually fall together with him. And always warn the patient before. And this test, I would say the patients are normally very fearful. So you have to tell them and warn them much way before you pull them backwards. So this is a home video of one of my patients. And this is just to show you gait assessment. So when we look at the gait of a patient, we look at a few parameters. Number one, we look at the speed of the gait, how fast the patient is walking. Number two, we look at the step length. The third, we also look at the arm swing of the patient. and we look at it bilaterally, and also we have to determine whether one side is worse than the other. We look at foot clearance, and we look at how the patient turns. So you have to do the patient walking a certain distance and then turn back as well. So you can see he has this stoop posture. You can see the facial hypomimia, the reduced arm swing, which is more on the left compared to the right, a very small stride length, and a bit difficult in clearing the foot. And as he turns, a bit of freezing over there, and then he tries to turn with a few steps, and then goes backward. So now he sees the box, the box on the floor, and the stride length becomes slightly better. So that is sort of a visual cue in this patient. So similarly, in this patient, the freezing, he freezes so badly that he cannot even lift up the foot to take a step forward. But freezing of gait is amazing in the sense that with the visual cue, you can see how amazing he walks now. So there are ways to help in the management of this. And if you need more devices like the laser cane and all that, I think Ron Rouge has a whole set of it now and very upgraded by now. So we look at other Parkinsonism condition with gait disorders, and not all of them looks like Parkinson's disease. So you can see that this one is a bit broader base compared to the previous video. And you can make a guess that this patient doesn't have Parkinson's disease, but has an MSA. The second one, you can see a bit of sway, a mediolateral sway, and also wide-based gait in a patient with Parkinsonism. And this is a patient with progressive supranuclear palsy, PSP. The third one, a patient with gait apraxia, has very difficulty even lifting up the foot. And as you can see, his daughter sort of becomes very impatient. Why can't you just take a step forward? And he slides the whole foot, and that makes him cannot walk at all. And he responded very well to VP Shan. He's a patient with NPH, normal pressure hydrocephalus. And sometimes you see a patient that has predominant lower limb Parkinsonism, but the upper limb is almost very slight Parkinsonism features. It's a patient with vascular Parkinsonism, so lower body Parkinsonism. So this is from the same article just now, VRD. You look at the footfall patterns, they are a bit different. They are different actually. In PD, you get the narrow-based characteristics. You can get some freezing of gaits in between. But in MSA and PSP, in MSA, a lot of times you see them broad-based, and in PSP, broad-based with the increased mediolateral sway. Also, another thing important when we do our examination, when the patient comes to the clinic, is that we have to look at the timing when the examination is done in relation normally to the medication, the levodopa that the patient takes. And as you can see, this patient, when he comes in, he has minimal Parkinsonism features, but he has choric movements, or what we call as dyskinesias, oral, lingual, even at the cervical region, and also the upper and lower limbs. So that's because it's at the peak dose of his levodopa, and he came in with a peak dose dyskinesia. But we wait long enough, the examination. Now all the Parkinson features come in. He has this rest tremor, he has the rigidity, he has the slowness, he has the typical resting tremor. So the timing is important, because if you do a unified Parkinson disease rating scale 3, you'll find that the scores are different when you do it when a patient is on or when the patient is at off. Okay, we move on to atypical signs and red flags. So features predictive of atypical Parkinsonism, the ones highlighted in blue are most of the time the ones that we need to examine. So we look for gait instability and falls early. Absence or paucity of tremor, irregular jerky tremor or myoclonus, which you have seen. Additional features, the eye movements and the cerebellar signs are important. Then you watch out for things like the stridor, dysarthria, dysphonia, the apraxia, alien limb and myoclonus in corticobasal syndrome. And always do a test, maybe probably a Montreal cognitive assessment to determine whether the patient has dementia and how many years has it been since the patient has been diagnosed to have Parkinsonism. So the eye movements, I would say that majority of the time, the abnormal eye movements would be in cases of PSP, progressive supranuclear palsy, where they may have slowing of the downward saccade, supranuclear gaze palsy, the vertical eye movements, round of Hauser signs, square wave jerks. In MSA, you may have gaze evoked downbeat and rebound nystagmus, and you have may have impaired smooth pursuits. So this is an example of a square wave jerks. You ask the patient to look far and you see this saccadic movement. And the second one, you have a patient, also a bit of horizontal gaze palsy, which comes in normally later as compared to the downward gaze palsy. And you do a corrected dulse, and normally when you move the head backwards dulse, the eye can actually come down. Cerebellar abnormalities, dysmetria in this patient. She was diagnosed as Parkinson's disease before seeing me, and came in with almost a near syncopal attack because her blood pressure dropped to almost about 70 because of challenging of the levodopa dose. And we know that in MSA, if especially not the early period, they do not respond that well as compared to Parkinson's disease. So too much of levodopa, she developed postural hypotension. But when you see this type of patients, you may not be dealing with Parkinson's disease, but probably MSA. Another interesting sign that you may want to just be part of your examination would be what we call as the applause sign. And the applause sign is somewhat a perseverative behavior where the patient continues doing the applause because we are testing on hand clapping. And this may suggest a severe frontal subcortical or caudate dysfunction. So you ask the patient to clap 3 times. And they continue doing it more than 3 times.
Okay, so in one setting, just 3 times. In one go, clap 3 times. 1, 2, 3. No.
There is 4 times he claps. So it's sometimes helpful to discriminate things like PSP from FTP and Parkinson's disease.
Thank you.
So besides the motor examination, the cognitive and behavior examination is also somewhat important. Always do a Montreal cognitive assessment would be a more sensitive test as compared to the mini mental state examination. The frontal lobe dysfunction, you may want to do a frontal assessment battery, and then look for aphasia, speech apraxia, mood assessment. As we know that depression is very common in patients with Parkinson's disease. Look for emotional lability, obsessive compulsive disorders, hallucinations, and delusions. So if you see a patient like that coming into the emergency and has been diagnosed with some form of Parkinsonism, the stridor, always think of multiple system atrophy, MSA, and that's the contractures in a patient with MSA. So they may get more dysphagia, more stridor. Sometimes you get pyramidal signs, hyperreflexia, Babinski, enterocolis, and striatal deformity or contractures. So the theory is either the neurogenic atrophy of the posterior cricoarytenoid or the dystonia of the adductor muscles. So if you suspect a patient may have atypical Parkinsonism and it's asymmetrical, you may want to ask them to do certain tasks. For example, show me how you brush your teeth, or show me a peace sign, or show me a love sign or something. And they can't do that movements on one limb. For example, in this lady, he has very difficult motion on the right side. She thinks that the limb doesn't belong to her anymore. So this is a patient who had corticobasal syndrome. So I come to my last slide. And so in summary, the examination based on the goals of 3, which I mentioned. Well, number 1 is to determine Parkinsonism, looking for bradykinesia, rigidity, resting tremor, look at the posture, look at the gait of the patient. Second, after you have determined Parkinsonism, look for red flags or signs to suggest atypical Parkinsonism, which I've showed you just now. And the third one is that do not miss things like mimicus, some things that look like Parkinson's, but it's not. Second is the observe carefully while taking this history, so you can save a lot of time because you have already done a lot of the examination while taking the history. It means you do it both together. And third is always examine the gait of the patient. And sometimes with good technology now, a lot of signs or things may happen at home, but because we are with the patient for maybe only 10 minutes, 15 minutes, we don't see the features at home, and a lot of time the relative will show you, hey, can you just have a look at this clip that I took with my handphone? And I find that very, very useful and important, because when the patient comes to the clinic, they may be a different time, they may be on an on period, they may have mild dyskinesia, but at home it's different. So always look at the home videos also. So with that, I hope you enjoyed the lecture on this topic, how to examine a patient with Parkinsonism. Thank you very much.
Yes, that's quite an impressive video collections. Tian, thanks very much. Probably we have time for one quick question. Any question at all? So, Tian, maybe I could ask for your tips really, because there are a lot we can do with the examinations, but I just want to ask in your own practice, when you have a short period of time, what would be your tips to quick examination to determine whether that patient has Parkinson's disease over other atypical Parkinsonian disorder?
Thank you for that question. So yeah, I mean, I was talking to Tai and said, how many patients do we see a day? Sometimes we see 40 to 50 patients in a day. And to really thoroughly examine one patient for 30 minutes is quite impossible unless we decide to go back at midnight. And the day continues the next day. So there are certain tips, I would say, that we look for in a patient to look for atypical Parkinson as compared to Parkinson's disease, because that would actually change the prognosis and also the treatment for the patient. I guess the first thing is like what I mentioned, is to look at the faces and how the patient walks in. But the second tip would be, if you see a patient that has been newly diagnosed or has only had symptoms for maybe a few months or less than a year or within 3 years and is on a wheelchair, that triggers me that this cannot or is quite rare to be Parkinson's disease to be on a wheelchair, unless of course she has other reasons like maybe osteoarthritis of the knee together with Parkinson's and so on. So on a wheelchair. The third is to determine whether the patient has been treated by other physicians or neurologists or movement disorder specialists and on a relatively high dose of levodopa, and they do not respond that well, or the family is still not happy with the outcome of the treatment, then you think again, are we really dealing with atypical Parkinson? So, I mean, normally we say about 800 milligrams to 1000 milligrams of levodopa, and still the patient is having a lot of stiffness, rigidity, bradykinesia. And of course, and the asymmetry of it, you don't really see the asymmetry and the absence of tremor. That would also trigger me to point out to atypical Parkinson's. And I guess the rest I've shared in the lecture.
Thank you.
Thank you.
Thank you very much. So let's go to the next session. I think we cannot have the topic in the movement disorder conference without the topic on Parkinson's disease. And this topic is going to be given by the person here who does not need any introduction at all, Professor Tai Tran. He will deliver the lecture on Parkinson's disease diagnosis and therapeutics concept. Welcome, Dr. Tran.
Thank you, Professor Virajasri, for your introduction. Good morning, everyone. Now I would like to share with you the topic Parkinson's disease diagnosis and therapeutics concept. I don't have any disclosure for this topic. At the beginning, I would like to share with you some clinical case. You can see here, this is the male with 56 years old. He suffered from the smell loss for 2 years, and 1 year later, he suffered from the slow movement and mild tremor on the left side. On examination, which is he has a nose Smith and left side Parkinsonism with UVD at past 320. He is diagnosed with early Parkinson's disease, and you can see here, this is the woman. She suffered from slow movement and mild tremor on the right hand, and she also diagnosed with mid-stage Parkinson's disease. And this is the third case. He suffered from Parkinson's disease for 12 years, and now he have freezing upgrade and have dyskinesia on medication, and he diagnosed with advanced stage of Parkinson's disease. So you can see Parkinson's disease is chronic progressive neurodegenerative disease, and clinical manifestation include rest tremor, rigidity, bradykinesia, and postural disability. The mean of age of onset is 65, and it affects 1% of the patient more than 60 years old. This is the map of the prevalence of Parkinson's disease in the world. You can see the prevalence varies by region to region. So in our region, you see the prevalence about 80 to 100 per 100,000 population. And this map is shown by Professor Virajasri, and you can see the picture of our region, Indochina region. How about the neuropathology diagnosis? As you know, neuropathology diagnosis is still considered as a standard of the diagnosis of Parkinson's disease. And in this pathology, you can see compared to the normal people, the Parkinson's disease people will have the loss of pigmented substance nigra compactor, and they also have the loss of dopaminergic cell, and in the cell survival, there are the presence of Lewy body and alpha-synuclein, and that is the standard for the diagnosis of Parkinson's disease in pathology. So how about the pathological progressions of Parkinson's disease? According to hypothesis of Parkinson's disease, we will have 6 stages. In the stage 1 and stage 2, the pathology effect on the oblongator medulla, and the effect on locus coeruleus, and also 9-10 nucleus. And that stage in the clinical is the prodromal syndrome. And when the disease progresses to the stage 2 and stage 3 and stage 4, the motor symptom begin. And you can see here the pathology effect on the mesocortex and substance nigra. So that's why the motor symptom occur. And to the stage 5 and stage 6, you can see the pathology effect on the neocortex. So some symptoms such as dementia, such as possibility postural instabilities appear. So that is the symptom resistant to levodopa. So how about the clinical progression? With the paradox hypothesis, you also see the timeline of progression of Parkinson's disease in the clinically. You can see here in the stage 1, stage 2 of hypothesis, we will have the prodromal Parkinson's disease, and at that stage, the motor symptom, we don't have a motor symptom. And when we in the early stage of Parkinson's disease, the motor symptom, bradykinesia, rigidity, tremor appear. And when the patient move to the middle stage, and some motor complication appear. And when the patient move to progress to the late stage, we can see the postural disability and falling, freezing, dementia will appear. So that is the progression of the motor symptom in Parkinson's disease. And how about non-motor symptom? In Parkinson's disease, you know, non-motor symptom also very important for the patient. So you can see the non-motor symptom can appear every time of the progression of the disease. At the prodromal stage, we can see some REM sleep behavior disorder. We can see constipation, depression, and after that, we can see autonomic dysfunction and cognitive impairment. How about the survival of Parkinson's disease? You can see in this chart the survival core of Parkinson's disease when we compare the Parkinson's disease patient with the reference group. You can see in the first 5 years, the survival is the same between 2 groups. But after 5 years, the patient with Parkinson's disease will have the lower of survival compared to the reference. And at the after 15 years after the diagnosis of Parkinson's disease, we can see the patient with Parkinson's disease will have dry times lower than in reference group with survival. So how we can match the diagnosis of Parkinson's disease? We are the neurologists, we are the doctor. We can see the progression of Parkinson's disease for a long time. When we catch up the patient at the prodromal Parkinson's disease, how we make the diagnosis. And when we catch up the patient at the early stage, the middle stage, and the late stage, how we make the diagnosis. At the early stage of Parkinson's disease, we also, we have many criteria for the diagnosis of Parkinson's disease. So this is the criteria we usually use. That is recommended by MDS. In this criteria, we need to have the essential criteria for the diagnosis. At first, the patient must have a bradykinesia, and the patient also have the combination of at least one of rest tremor or rigidity. When the patient have a bradykinesia and rest tremor or rigidity, the patient will enough for the essential criteria for the diagnosis. And after that, we will diagnose the patient with clinical established Parkinson's disease. We need to check to examine the patient to rule out the absolute exclusion criteria. The patient also don't have any red flag, and the patient have at least 2 supportive criteria. At that time, we will make the diagnosis of the patient with clinical established Parkinson's disease. And how about the clinical probable Parkinson's disease? We will make the diagnosis when the patient also have no absolute exclusion criteria, and the patient will have the presence of red flags counterbalance by supportive criteria. That means if the patient has 1 red flag, they have at least 1 supportive criteria. This is the absolute exclusion criteria. You can see there are 9 features. I think we can checklist in the paper to check the patient with Parkinson's disease must don't have any feature of this exclusive criteria. And we also check the red flags. This is 10 red flags. So we must checklist and to rule out the red flags when we want to examine the patient with Parkinson's disease for the clinical establishment. And this is a supportive criteria. Yes, we have 3 supportive criteria for the diagnosis of the patient with early stage. Yes, rest tremor of a limb, the presence of either olfactory loss and cardiac sympathetic denervations on MIBG scintigraphy, and the patient also respond very dramatically and clearly to dopaminergic therapy. If we catch up the patient at the late stage, the middle stage, how can we do diagnosis? So we also use this criteria, but you must review all the absolute exclusion criteria and review all the red flags, because at this stage, maybe the patient will appear the red flag, maybe appear the absolute exclusion criteria. So we must review the patient. We will re-examine the patient again to check, to rule out it. And how about the supportive criteria? beside three features I have talked, we also check the patient with the presence of levodopa in induced dyskinesia. So if the patient have more supportive criteria, we will have an opportunity to make the diagnosis. What is the clinical diagnosis accuracy for this criteria? You can see this is the clinical study. Yes, and the study showed us the overall accuracy for probable Parkinson's disease were 92.6%. So you know this is a clinical study. The gold standard for this studies is the experts movement disorder expert role. So I think we need another study, the clinical pathological study to validate this criteria. And what is the accuracy between the early and advanced Parkinson's disease diagnosis? As you can see in the early Parkinson's disease, the accuracy of diagnosis is lower. For in this studies, it shows just 53% compared to the advanced Parkinson's disease. In advanced Parkinson's disease, the diagnosis is better. And you can see 88% of the patient with Parkinson's disease can diagnosis exactly in the advanced state. So, and how about the prodromal Parkinson's disease diagnosis? When we catch up the patient here, how we make the diagnosis? You can see this is just research criteria for the prodromal Parkinson's disease. That's also updated by MTS in 2019. And but you know, this is just the research criteria. In this criteria, we must do three steps. The first, we must estimate the prior probability, and the second, we calculate the likelihood ratio marker, and the third, we estimate the post-test probability. With the prior probabilities, we estimate by the prevalence. For example, if the people at the age of 50 to 54, the prevalence of Parkinson's disease at this age is 0.4%, and with the age more than 80 years old, the prevalence is 4%. So that means the prior probability. And then we must looking for all the risk marker and all the prodromal marker. For example, if the patient is male, the likelihood ratio positive is 1.2, and if the female, the likelihood ratio is minus 0.8. And if the patient have the first relative for Parkinson's disease, and the likelihood ratio is positive 2.5. And how about the prodromal marker? If you find that the patient have the REM behavior disorder proven by polysomnography, and you can see the likelihood ratios very high, positive for 130. And then we multiply all the risk marker and all the prodromal marker together. So on this diagram, monogram, you will have the pretest probability here, and we will have the likelihood ratio here, and we draw the line, and we can have a post-test probability. And probable prodromal Parkinson disease would refer to the high likelihood with post-test probability more than 80%. We also had a calculator for calculate the prodromal risk for Parkinsonism on MDS website. We move on the treatment of Parkinson disease. As you know, Parkinson disease still remains a progressive disease without a cure. And the disease modifying therapy has continued to fail. Symptomatic treatment are highly effective in clinical. So when we see the timeline of the progression of Parkinson disease, we also have the timeline of the treatment of the Parkinson disease. For example, at the preclinical Parkinson disease, we can manage the non-motor symptom, but without motor symptom. And we also don't have any disease modifying therapy. But at the early stage, we can use medication to treat the motor and non-motor symptom. But when the patient have a motor complication, we began to consider the invasive therapy, such as apomorphine infusion, LCIG, levodopa, carbidopa, intestinal gel infusion, or different stimulation. And when the patient have the delay stay, and we recommend stronger with the invasive therapy. But if the patient very late, at the very late stage, we cannot use invasive therapy, and medication will also reduce gradually. At that time, the patient will be disabled. At the early stage, we have the guideline for the treatment at the early stage. This is the American Academy of Neurology guideline in 2021. At this guideline, when the symptoms are not causing disability, most individuals in Parkinson's disease and clinicians are comfortable with wait and see approach. However, careful monitoring and advising the patient do not tolerate the disability or reduce the quality of life unnecessarily. But when we need to use the medication for the patient, which medication you choose at the early stage, we can choose levodopa, dopamine agonist, or MAO inhibitor. With levodopa have the greatest benefits, but levodopa also have more dyskinesia. But with dopamine agonist have the moderate benefit, but dopamine agonists also have the high risk of impulse control disorder, ICD, and with MAO inhibitor is with benefit. So there are some features to prior to choose the medication. For example, with levodopa, we can choose levodopa for the patient more than 70 years old, and for the male sex, for cognitive impairment, psychosis, overweight, history of ICD or addiction, and we can use the dose less than 400 milligrams per day. With dopamine agonist, we can use for the patient younger than 60 years old. And the female sex, the patient don't have no cognitive impairment, no psychosis, lower body weight, no history of ICD or addiction, as no excessive daytime sleepiness. And with MAO inhibitor, we can use for the patient with mild symptom, mild motor symptom. And how about anticholinergics? We also use anticholinergics only for tremor. You can see on this review, the doctor, the author suggests to use anticholinergics for the only tremor. And you can see anticholinergics also using for many countries now, up to now. And in the advanced stage, how do we treat the patient with the advanced stage? At the advanced stage, the motor symptom will have more. So this is a guideline. This is the update for the treatment of Parkinson. For treatment of motor symptom of Parkinson disease, you can refer. And you can see there are many kinds of medication for Parkinson disease up to now. We have levodopa growth with levodopa oral, levodopa inhaler, levodopa infused in gel infusion, and we also have a dopamine agonist for oral, for parts, and for injection for sublingual. And we also have a zonisamide, AOB, MAO inhibitor, COMT inhibitor, anticholinergics, anti-NMDA, and adenosine antagonist. However, you see, as you see the picture, the slide of Professor Peter Sassari, in our region, we have levodopa. Most of countries have levodopa, and most of countries have a different stimulation. But another, some country have, some country no. So when the patient from the early stage to the middle stage, the patient will have some uncontrolled symptom. So at that time, we can increase levodopa more than 400 milligrams per day, or we can increase the dose of dopamine agonist, and we also a combination of medication. When the patient have motor complication, we also adjust levodopa. We also use polytherapy, and we also use invasive therapy. With invasive therapy, we can use apomorphine injection, or LCIG, or functional neurosurgery, deep brain stimulation, listening, focus, ultrasound. How about the non-motor symptom? You know, non-motor symptom also very important, and the patient, all the timeline of the progression, you can see many non-motor symptoms. So you can use the updates of treatment for non-motor symptom of Parkinson disease on MDS guideline, MDS review in 2019. So we can see can use it, and we also use rehabilitative therapy for all the symptom and all the state of Parkinson disease, such as do exercise, physical therapy, occupational therapy, and speech therapy. And I summarize the progression of the treatment of Parkinson disease from the early stage. We can use levodopa or non-levodopa. And on the advanced stage, we can use levodopa modification or polytherapy adjustment. And when the patient have a motor complication, a motor fluctuation, we can adjust polytherapy. And when the patient have the dyskinesia, we can also adjust polytherapy, and we can add amantadine or clozapine. And after that, we can use invasive therapy. At the same time, we also manage the non-motor symptom, and we also use non-pharmacological therapy for the patient. In conclusion, Parkinson's disease is a heterogeneous and complex integrity. The diagnosis is very challenging for some cases, and current therapies manage the symptom effectively and improve the quality of life for the patient. And we also need more clinical trial with disease modifying therapy. Thank you very much for your attention.
Thank you, Dr. Tai, for your comprehensive talk on the diagnosis and management of PD. Any question, please? Dr. Professor Gao.
First of all, I would like to thank you for a very useful presentation. And I have one comment and one question for you. Several years ago, we had a trial to use nilotinib to stop the progression of Parkinson's disease. But then we had to stop our trial after the information from Pagan and his co-worker from United States that nilotinib is not effective on Parkinson's disease progression. It was a very disappointed information for us, but we have to agree with him and with you too. Thank you. We have nowadays no cure therapy and no modifying treatment for Parkinson's disease. And I would like to have a question for you. Thank you for your case presentation about anosmia and how to differentiate between anosmia with Parkinson's disease and with Alzheimer's disease. And if you have some devices to test the anosmia in Parkinson's disease. That's all.
Thank you very much for your question. With anosmia, with me, I can differentiate between the anosmia in Parkinson's disease and Alzheimer. But some studies show that in Parkinson's disease, in anosmia, maybe have the patient will have the loss of the smell for some odor, and in Alzheimer, the patient will have the loss of other odors. So a little bit different between two groups, but in clinical with me, I can differentiate between them. Thank you.
How about your opinion, Professor Rongroy?
Right. So probably we don't utilize the smelling function as a primary tools to differentiate Parkinson's disease from the Alzheimer's. I think that to get the information from both group of patients can be quite challenging a bit, and I think that it's also depends on the cultural and their background influence too. I believe that our group, Dr. Chakota, she did quite extensive work on the smelling function and also gustatory function in patients with Parkinson's disease. She found some disturbances in patients with Parkinson's, but she also identified some regional influence of these recognitions of various smell and taste perception too. So I believe that you will find the abnormality, whether it's sensitive enough to distinguish between the two. I'm not quite sure. We don't use it primarily because other clinical features probably they are more sensitive to differentiation.
Any other question? I think that many attendees are waiting for some more comment from Ron Roy about this topic. Do you have some more comment?
Yes, I mean, this is like a, like a bread and the butter of our movement disorder practice, that we need to recognize these Parkinson's. But, as, Professor Tan has outlined that, it is still a challenge to diagnose early Parkinson's in clinical practice. And the number that you demonstrated, I think, is reflected very well that accurate diagnosis of early Parkinson's is not easy at all. Maybe you can share your tips again, if I ask about the tips for examination or detecting early Parkinson's disease in your practice. What would be your clinical clues to for early patients?
Thank you. In my clinical practice with the patient at the early Parkinson disease, when I examine the bradykinesia, rigidity, and rest tremor on one side, I also to check all the non-motor symptoms, especially anosmia. If the patient have anosmia, we will increase the opportunity to make the exact diagnosis. And we also check all the non-motor symptoms, for example, REM behavior disorder, the generation, the relative with Parkinson disease, etc. And all the symptoms help us to make the diagnosis of early Parkinson disease exactly. That is very important in clinical. But there are some imaging can have, but in my country we don't have. For example, dopaminergic imaging or ultrasound, etc. We don't have. Thank you.
Okay, no more question. Then I think we have to move on now to the video session. Dr. Lim Thiên Thiên and Dr. Lê Uyên, please.
I think the video session will be a bit more the fun part, isn't it? So maybe we could do a bit more interactive. The audience could participate, and maybe we all can join in with thoughts and forth and on the cases you're going to present. Thank you.
Yeah, thank you. So good morning, everyone. I'm Uyên Hà. I'm from University Medical Center. And firstly, I'd like to express my gratitude to the organizing committee to let me have a chance to stand here. And this is my very first time to present in front of so many audiences and so many renowned experts. So please excuse me for any mistake there may be. In the first part of this session, I discussed two cases. My first case is on 37-year-old male who experienced initial symptom in 2017. He got a diagnosis of PD and was put under treatment in 2018. And since 2020, he has had motor complication, including fluctuation and dyskinesia. In more detail, in 2017, the patient initially noticed his slow walking and forward flex posture. 8 months later, he experienced progressive stiffness and up his right leg. And at that time, he got a diagnosis of young onset Parkinson disease and received treatment. In now the first 2 years, he reported a good response to the medication, but later he noticed a gradual decrease in duration of benefit from each dose, which resulting in medication increase. And as a consequence, dyskinesia also appear. To control the motor complication, the medication adjustment, including levodopa fractionation and increase in dopamine agonist dose was made. And in the beginning of this year, he came back to our clinic, and his caregiver told us about his strange behavior. He kept buying many unnecessary things. He became addicted to online gambling, which then led him to much debt. And he also admitted that he had an increase in sex drive. And when he looking up for information online, he knew about the side effect of pramipexole, and he decided to stop using it for a week on his own. And after that, his motor symptom rapidly got worse, and he had to get hospitalized. And this the medication, the latest prescription before he stopped using pramipexole. He had levodopa, carbidopa 6 times a day, half a tablet, pramipexole ER 4 tablets a day, and he also used amantadine twice a day. So as the recommendation from the chair, so is there anyone want to comment on this patient?
Okay. You can ask for the volunteer first, of course, but if there are no volunteers, you have the privilege to pick who you like to discuss. What about that?
Okay.
What would be your question, though? What is your question to the volunteers?
So do you have any comment, or do you recommend any diagnosis for those unusual behavior of the patient?
Okay. So maybe, what are the symptoms, and how would be the management, isn't it?
Yeah.
All right. Okay. I need to stand up and walk a bit, I think. Otherwise, I'm going to go, having daytime somnolence too. So any volunteers? Yes, thank you. Thank you very much. I think the neurologist from Hanoi, right? Okay, thanks so much.
Okay, thank you very much for the case. I think the patient have ICD, invasive obsessive disorder, and that's why he need to stop pramipexole, and we can increase levodopa, and we use together with amantadine, because amantadine will help with the dyskinesia, and the patient can be also the good candidate for DBS. I think so.
Yeah.
Thank you.
Thank you.
Thanks so much.
Yeah, due to the severe motor deterioration, so he came to our hospital and he had to got hospitalized. And this is the video of this patient. This video is recorded during his off state. So as you can observe in those videos, the patient had a bilateral severe bradykinesia, more prominent in lower limbs. He barely moved his leg. This is what he do when when we told him to stand up. He cannot stand up on his own.
Cố gắng để coi như thế nào. Đứng lại vậy nè, cố gắng lại vậy ha. Thì có người đỡ vậy hay thử có nổi không nha. Được không? Được ha, đợi. Đừng vậy ha, rồi đứng dậy giùm em ha, thử có nổi không?
He needed assistance to stand up. This is his gait, and he has a bone stats. He can recover on his own. He ragging his leg while walking. So when we assess this patient, the MDS-UPDRS scale resulted 7 in part 1, 13 in part 2, 51 in part 3 during off state, and 43 in on state. And the part 4 resulted 7 years old. He had a normal cognition, no depression. And to assess the complaints of the patient and his caregiver, we use the QU-IPRS diagnosis tools recommended by MDS, and we found 2 behavior related to impulse control disorder, as mentioned by doctor. And those behavior include gambling, hypersexuality, and compulsive buying. So we decided to adjust the medication for this patient, and we do increase the levodopa and carbidopa up to third quarter, 6 times a day. But we don't think that we should stop using pramipexole immediately. We need to gradually decrease the dose in pramipexole. So we reinstate pramipexole back with half of the previous dose, and we continue to use the amantadine. So through this case, I want to remind of an undiagnosed complication in Parkinson's disease, which is impulse control disorder. ICD may occur in 14 to 40 patients with Parkinson's disease. And the most common behaviors include pathological gambling, hypersexuality, compulsive shopping, compulsive eating, hobbyism, bonding, and compulsive medication use. QU-RPRS is useful for diagnosis, screening, and severity grading. And the widely accepted risk factor include dopamine agonist use, younger age at disease onset, male gender, and prior history of anxiety or depression, substance use, REM sleep behavior disorder, or a higher rates of dyskinesia. And the patient in this case had many of risk factors. And the first line management include gradual dose reduction and complete withdrawal of dopamine agonist if possible. And I think we need to reduce or adjust the dose slowly because the abrupt stop of dopamine agonist can lead to many complications. Yeah. And in the second case.
Okay, may I pause you for a
Okay.
minute, because I think that you show a very good case here. Can you go back to the that MDS-UPDRS?
Yeah.
The one before.
MDS-UPDRS. Yeah.
Okay, I think this is quite important, and it tells us a lot of things. And as the doctor mentioned that he might consider DBS, right, for this patient. Would you, based on the information here, so maybe can discuss a bit, would you consider DBS in this patient? Any comments at all? The history, young onset Parkinson's disease, clearly have the fluctuations. But interestingly, you get this number on the screen. Would you?
I think I'll be quite worried to do it immediately because, I mean, although DBS can be used as part of the treatment nowadays to treat neuropsychiatric problems, but in a patient who has ICD score QIP-RS 23, depression scale as well, which is 10, is it? The max depression. So I would normally reduce the dopamine agonist until the neuropsychiatric symptoms are quite well controlled first. But I guess there is indication in terms of the wearing off effect and the motor complications in this patient, where she's already on 3-hourly levodopa. And when we reduce the dopamine agonist, the motor symptoms become even worse, and that would probably affect the functioning. So, I would say yes, but probably not immediately.
Yes, that's a very good point. The other thing that I want to point out here, that if you look at the part 3 score, you see that on and off, the difference is not that much. It's 51 and 43. However, the patient has a dyskinesia already for 60 minutes. You know, it tells us something, isn't it? That what does it mean by that on-time MDS-UPDRS with the dyskinesia observed, and the part 4 is already scored 7. So I found that there is a little bit not clear cut there. But I just want to point out here is that there is already a consensus Delphi panel on the criteria for considering device aid or device aid therapy in advanced Parkinson's disease patients. And I think that we know some of the important indicators, like for example, off time, disabling off time for at least 2 hours per day. This one thing. Disabling dyskinesia, taking medications more than 5 times a day. Those are the important indicators. And for considering, deep brain stimulation, for example, but I just found that there a little bit discrepancy. So I would be very careful in considering the deep brain stimulation for this patient with this type of scoring, though. Any other comments? Okay, good case. The other thing that I thought that this case is quite strike me is that the patient decide to stop pramipexole himself. That is very brave for the patient. I have not encountered patients that decide to stop the dopamine agonist him or herself, particularly young onset patients, by finding the side effects of the medication, and then, okay, I better stop it. And so that is quite a courage of the patient, really. Yeah.
Yeah. He's a member of a Parkinson's disease patient club, and they share information, and he know about ICD, and he stopped using it on his own. Yeah. Yeah. Thank you so much. And my second case is on a 48-year-old female who came to us because of difficulty in walking, which respond poorly to the medication. Regarding the patient history, since 2015, he reported of frequent talking and limbs movement during sleep. He also had quite severe constipation, which make her regularly visited gastroenterologist. But not until 2019, she reported the first motor sign, which is slow movement and stiffness on her left hand, then spreading to her left leg. 8 months later, she got diagnosis with Parkinson's disease and received treatment. In the first 1 year, she had a partial improvement with medication. But after that, she had a poor response to medication. She started to have other abnormal movements. She also had progressive balance impairment and frequent and urgent urination. In the beginning of this year, she started to have urinary incontinence, and the gait disturbance is so severe that she have frequently fall, and her caregiver also reported of several syncope attacks, and they also noticed stridor during her sleep. Yeah, and her previous prescription before coming to us, she used levodopa, carbidopa 5 times a day, and bromipexone 3 times a day. So this is the video of the patient. On the left side is during off stage, and on the right side during on stage. Oops. Sorry.
Okay.
Oops. Let's wait for me.
So right, we experience observe, but we can see it upside down. It's no problem. It's the building we are in. All right. Okay.
I hope you can see it. During his off stage, she had a bilateral bradykinesia. She also have an ataxic gait. She need assistance her walk. And during her on stage, we can notice abnormal movement of her leg, her neck, and her right arm. During the on-stage, the bradykinesia did improve.
This is how many years of the symptoms now?
3 years after the onset of the first motor symptom. She didn't have ataxia of her limbs.
Would she declare that she had benefits from the medication?
Yeah, she did have the benefit from the medication, but with the bradykinesia, the stiffness and slowness of her hand or her move, but the gait or the balance symptom did not improve with medication. Yeah, and other sides not shown in the video. This patient had a normal consonance, normal range of eye movement, no spontaneous nystagmus. She had impaired smooth pursuits and intact saccade. She didn't have limb ataxia. She had a hyperreflexia and Parkinson's sign on her left side. She lost of postural reflex and had a ataxic gait. And to assess the patient, the MDS UPDRS resulted Part 1 E15, Part 2 28, Part 3 during upstay E56, and Part 3 onset E32. The normal cognition with MNSE E29. And because of the history of several syncope attacks, we evaluate the blood pressure and the pulse in different positions. And she had a severe drop in her blood pressure within 3 minutes of standing to 65 per 50 without the pulse increase. So to sum up, this is a 48-year-old female with 3-year history of progressive asymmetric Parkinsonism with partial response to levodopa. She had fluctuation in levodopa dyskinesia. She had postural instability, neurogenic orthostatic hypotension, and urinary incontinence. So the question is for the audience. Do you recommend any differential diagnosis for this, or do you have any other diagnosis for the patient?
Okay. Yeah. Okay. Any comments? She asked for not only one diagnosis. You asked for the differential diagnosis, right? So that person needs to give the differential. Can you speak louder, please?
Yeah, we do have a MRI. Okay, we're going to show. Okay.
She wants a differential first before the MRI.
I think that with the picture, clinical picture, is maybe
So there's some
MSA,
slices of.
it's a MSA.
But I think clinically, it is very suggestive.
Yeah,
Of, already very suggestive of one another.
yeah, for everything,
Parkinson
for
is the syndrome.
yeah, for everything we have in summary for this patient is the patient young onset with Parkinsonism and with a lot of symptoms, for example, fluctuation and levodopa dyskinesia, postural respond partly with levodopa, and especially the patient have a nocturnal sclerosis is typical signs of MSA. And I think it's MSA, because I need more detail for confirming the diagnosis on.
But clinically, Dr. Tuan, what do you think? What is your impression, your clinical impression about the diagnosis of this case? Can you have your comment before before looking at the MRI. Okay.
Yes, I think it's MSA.
Okay.
Doctor.
Are you agree? Okay. What MSA? What type of MSA? P or C? Pardon? MSAC is a C. Okay. You can ask.
Think there is the presence of Parkinsonian, right? And you think it is a C type of MCA?
Do we agree? Do you have
There,
a unanimous here?
MCA, MCP. You have to choose between
Any
the two.
other differential diagnosis? Because you are for the differential. Okay, that's one more. Go ahead, you take the microphone to that. Yes, I like this audience. They're very enthusiastic.
I think this patient had Parkinsonism and autonomic dysfunction. So MSAP is my diagnosis.
Because
this patient have Parkinsonism and autonomic dysfunction based on urinary incontinence and neurogenic orthostatic hypotension. So I think MSAP is my diagnosis.
Okay. Maybe if we could ask the expert, Dr. Lim, you to talk about you lecture this topic. Would you agree? Would you have any other differential?
Yeah, so it's always between whether it's Parkinson disease or atypical Parkinsonism in this case. And in this case, if the autonomic symptom seems to be quite prominent at 3 years onset, you sometimes do get a bit of asymmetry also, although I mean typically we learn that the atypical Parkinsonisms are symmetrical, but you can't get asymmetry. Even in PSP, sometimes you get some asymmetry as well. So yeah, MSAP, I would agree.
Can this patient still have Parkinson disease? Look at the score. MDS-UPDRS 3 is 56, part 3 is 32.
Nearly 40% improvement.
Is it still possible to have Parkinson disease? And what else in the differential? She asked for the differential. We have the ladies here. One of you has to speak, I think.
I have to discuss between two topics. It should be divided into two topics. One is that the patient with the suspecting of atypical Parkinsonism also have features of levodopa responsive. That's the one point. And another point is that for your question that whether this patient can have Parkinson's disease, I think yes, because all of you already asked for the differential diagnosis. Yes, one reason is that there is also levodopa responsive at least more than 30%. But this patient, if she has Parkinson's disease, it would not be the only one disease. It should be combined with another pathology, like maybe the vascular Parkinsonism, which may have gait or postural instability problems, and maybe combined with the other structural abnormalities, which we could see in the MRI brain. So for the differential diagnosis, I think it would be the MSAP, which has the features of levodopa responsive, and another differential diagnosis would be the Parkinson's disease combined with another pathologies like the vascular Parkinsonism or others.
So because I quite agree with you, these patients actually improve over 40% with the medication, has levodopa-induced dyskinesia.
Yeah.
And it's relatively young. To diagnose MSA in the early 40s, we have to be careful. It doesn't mean that it's not possible. It can, but early 40s, like 44 with MSA is a bit unusual there. The other point, maybe I asked Dr. Srinkian to comment, is abnormal breathing sound at nighttime. Would you always put that as a stridor?
Before we go to the abnormal stridor, may I comment a little bit? And I'm not sure she has a obvious move motor complication, right? Like end of dose and dyskinesia. She already have it.
Yeah, she
Oh,
already had.
Maybe another
Recently she has
one differential diagnosis that you keep in mind is that genetic Parkinson disease, like the Parkin mutation, which can cause in the young onset and early dyskinesia, for my opinion, apart from the MSA. That the question that Professor Pitayasiri asked about the stridor in in the nighttime.
Yeah,
It
but unfortunately, that patient was not. We could not put her in the polysomnography, and that is just a symptom reported by her caregiver, so we can't confirm it. We could. Yeah. But we didn't notice it during her hospital stay.
For the nocturnal stridor is one of the characteristic of the MSA, but you have to clarify it is the true stridor. And actually it can fall in the daytime, like also maybe during the awake stage, and you can find the evidence of the stridor. But another differential diagnosis of the nighttime voice or noise is maybe you have to exclude like OSA or another, or vocalization of the Parkinson REM sleep behavior disorder. Is my comment.
Okay, I think good cases really. Then I mean, they just want to point out here that I didn't mean that MSA is not likely in this case. It's certainly in the differential, but we need to be careful in the early 40s. The differential diagnosis of Parkinsonism with dysautonomia actually is very wide.
Yeah.
There are many conditions with the MSA mimics, so we need to be very careful about it.
Yeah.
And I don't know how much time we have.
Excuse me, I have questions. Is that very common that MSA patient they have Babinski sign? Is that common?
Yeah. It is included in the diagnosis criteria of MSA, so I think it's a quite common symptom of MSA. Yeah, hyperreflexia and Parkinsonism.
Yes, I'm neuromuscular. So I have silly question. I have to do all the autonomic tests in this hospital. So my question is, do we need autonomic tests to confirm MSAs? MSA is just a clinical diagnosis. And what is the value of autonomic tests in very end stage of Parkinson's disease? Do you do autonomic tests for this case at your center? Thank you.
Hey, who wants to answer this? I think it's going deeper and deeper now. And it also depends which autonomic test that you are referring to. Which one?
In this center, we have a composed of 5 autonomic tests,
wow,
including the SS, R, and it's 5 composed of 5 tests.
You do sphincter EMG in this case?
EMG, yes.
Sphincter,
no.
No.
Sphincter.
Okay, so what autonomic test were you referring to?
RR interval, SSR, orthostatic hypotension with the ratio of 38-15 ratio to confirm neurologic or non-neurologic hypotension. And isometric contracture.
I see. Yeah. Okay. Would anybody like to comment?
Some notification about the Babinski sign. The Babinski sign may be rarely, but maybe present in MSAP. But don't forget that there is also another sign, the I forget the two side of extrapyramidal syndrome.
Striatal.
Yeah, the striaton 2, the striaton 2. Maybe you can it is a Babinski side, but also you cannot avoid the striaton 2. Yeah.
Yeah. Possibly asking, are you sure that this is Babinski, or in fact it is a striatal?
Yeah, I'm quite sure that
Okay.
it's
It's certain it is a Babinski. Okay.
You can see in the video, there's no stripe.
All right. Okay. That topic is very important. Actually, it requires a long discussion. But I think that what test that we need is to differentiate between preganglionic and postganglionic disorder. Really, in this type of patient. So, like for example, if you have a cardiac MIBG, this patient would be a very good candidate for the cardiac MIBG to differentiate it.
Yeah. So. As you can, as we have discussed, this patient had many red flags, including gait impairment, severe autonomic failure. She also had a recurrent falls, and she had unexplained pyramidal tract sign, hyperreflexia. So we suspected of atypical Parkinsonism, and we have deliver a lot of investigation. This her MRI, as we can observe in this picture, there is a putaminal atrophy with the hyperintense dream sign bilaterally, and there's no atrophy of her points. So based on the recent published diagnosis criteria of MSA, this patient can have a clinically probable MSA because she have an autonomic dysfunction, Parkinsonism, and she didn't fulfill the criteria for the cerebellar symptom because she just have a case of ataxia, and she have 3 supporting motor feature, including rapid progression and moderate to severe postural instability and an unexplained Parkinson sign. And we decided that this patient had a clinical probable MSA type P. So through this case, I want to emphasize some points in diagnosis of MSA. The effectiveness of levodopa in MSA has been reported as 30 to 65% in both clinical and pathological cases. Motor complication has also all been reported in levodopa responsive MSA patient. So the occurrence of motor complication is not a reliable distinguishing feature of PD and MSA. And this is what I have been taught through of 5 years. Some atypical Parkinsonism may be phenotypically indistinguishable from idiopathic Parkinson disease during the first 5 years. And this is the end of my presentation. Thank you so much for your attention.
Thank you very much. Very good case, really. And I think that the other side of the motor fluctuation in MSA that I want to mention is orofacial dystonia, which we have not seen in this case. And the presence of autonomic dysfunction in this case that you documented, that was when she was taking levodopa. We need to be careful about it to claim that this is an autonomic feature.
Yeah. Actually, one differential diagnosis we think of at the admission of this patient, we can Parkinson disease patient have a severe hypotension, orthostatic hypotension due to the medication, high dose of dopaminergic hypotension medication like this one. Yeah. That's what we are afraid of, that hypotension is because of the high dose of medication. Yeah.
Thank you.
Dr. Yuan, with your new diagnosis, MSAP, did you continue the use of dopamine agonist like pramipexole? Because this patient has a very worse orthostatic hypotension.
Yeah, we gradually reduce the dose of dopamine agonist and withdraw dopamine agonist after this diagnosis.
Yes.
Thank you. Just a small comment for me for differentiate, for make sure the differentiate from Parkinson disease and MSAP for the previous patient. I think when you talk about the EMG of the anal sphincter, I think it is very important for this patient because we know that the MSA makes the degeneration of the ONAP nucleus. So maybe we will find out some activity of the innervation of the anal sphincter, and it will make the differentiation from the two diseases. Is for me. Thank you.
It is a very useful test, though, but it's highly uncomfortable to the patient, as far as I understand. And also nowadays, it's not entirely specific. It's highly suggestive, though it's not entirely specific. Post-residual urine is easy to do, to see if it's more than 30 mL. I think that is another thing that we use. Okay, sorry.
Oh, thank you. So I have two cases to share. So the first case, I will show you a video. 60-year-old woman who presented with stiffness of the limbs and frequent falls for about 1 year. And she's currently on levodopa benzorazide, 50-200 milligrams, 1 tablet 4 times a day. Can we have the sound?
Okay.
Yeah.
Go.
You see your answer now.
Not yet, not yet.
Go. Okay. One look for that look.
Táo nhỉ? Okay, so which Parkinsonism cardinal feature is shown in the video?
Okay, any answer?
A, bradykinesia, B, rigidity, C, tremor, and D, postural instability. Or we can ask how many say A. Just put up your hands. B, C, tremor, and D, postural instability.
I presume that the patient has D2.
Yeah. So the first part is you see bradykinesia, and then later on come postural instability. So that is shown. So the second question, are there features of atypical Parkinsonism? And if there are, what are they? Anyone wants to answer?
Okay, any volunteers? Yes, very good. Thank you.
Thank you. I see the cervical dystonia. I see the abnormal mobility of the movement of the eyes, her eyes. Maybe the retroscolis, maybe, huh?
Okay,
and,
good.
And the limitation of the vertical movement of the eyes.
Yes, abnormal vertical movements of the eyes, and also there's less blinking. And if you notice the face, there are ecchymosis bruises on the right cheek level due to a fall that you can see here, and also the chin. So she just had a fall not long ago.
Very nice.
And you can see the gait, a little white base and a little bit swaying on that side. So retrocolis, hypokinesia without decrements, early falls, wheelchair sign, limited vertical eye movements. The diagnosis?
Diagnosis. You can shout out what diagnosis. Who say that this patient doesn't have PSP? Okay, you agree that it's PSP?
Yeah. Okay, great. So PSP, progressive supranuclear palsy. So I guess there are more than one questions would like to ask this patient, but what would be the question you would like to ask if you see this patient in your clinic?
What question? Probably there are many questions.
Yeah, to determine whether.
Name a few. Yes, okay.
So I will push the question, Madam. Have you any difficulties for looking the objects in the at the lower position?
Okay.
What else? I think swallowing would be very important to ask about this
Okay,
patient too.
smell test. Yep.
Yeah. Yes.
I think that I will ask I will make the poll test for patient, and then I will ask when the time the first symptom appear and what the first symptom of the patient. I think that the patient have many time of fall before.
Okay, great. So I would ask whether there's a response to levodopa to determine it further. What bedside test would you do for this patient?
I think this doctor mentioned the poo test. That's one thing.
Okay,
to do.
yes.
Okay. What other bedside? I think doctor. What else? What bedside? You can name many, right? The choice is not limited to one, right?
Yeah.
Okay.
So I will do a Montreal cognitive assessment. Look for any early dementia in this patient. So PSP is a neurodegenerative disease, and typically it presents above 40 years of age, and it's a tauopathy. Presentation can involve the axial akinesia, rigidity, retrocolis, postural instability, early falls, and the supranuclear gaze palsy itself, or even slowing of the saccades only. Look for pseudobulbar dysphagia and dysarthria, and lack of response to levodopa and early dementia. It generally has a poorer prognosis than Parkinson's disease. And you can see these two patients with the characteristic, the procedural sign in the top patient and the retrocolic nature in this patient, and early falls. So these are some of the faces, patients with PSP that you can see here. And it's not just described. In fact, Charcot's in 1888 paper showing the feces of patients with PSP or atypical Parkinsonism. And even in the India group, you can see the procedural sign in the first one, the surprised look, the anxious look with chin dystonia, and mask-like faces. So look for all this. What next investigation would you do? You want to scan a brain imaging, and you can see that this hummingbird sign where there's atrophy in the midbrain, and the Mickey Mouse sign if you got the axial cut. So this is just the clinical criteria. I'll just go quickly. Probable PSP would be repeated unprovoked falls within the first 3 years and or tendency to fall on the pool test within the first 3 years. Progressive gait freezing, Parkinsonism, frontal cognitive behavior presentation. And you have these mandatory criteria, which is sporadic occurrence, age 40 or older at the onset of first PSP-related symptom, and gradual progression of PSP-related symptom. And you have the core clinical features, which would include the ocular motor dysfunction, postural instability, akinesia, and cognitive dysfunction. So if you have O1 or O2 and P1 or P2, you get a Richardson syndrome subtype of PSP. So you could take a look at this nice paper. We go on to the next case.
And I just want to point out that this patient probably has a clear Richardson phenotype, and the one that you mentioned there. Yeah.
So we go on to the next case in view of the time. A 48-year-old man with stiffness of the shoulders and upper limbs limiting his activity, like opening the door for 9 years. He has non-motor symptoms, poor sleep, anxiety, poor appetite, and depression. A Montreal Cognitive Assessment of 26 out of 30, which is quite good, and a Unified Parkinson Disease Rating Scale. At that time, because we had the old UPDRS scoring, so the on-off testing from 49 to 14 after levodopa. She's on Trihex, 2 mg 3 times a day, amantadine 100 mg 3 times a day, silagilin 5 mg twice a day, levodopa benzorazide 1 tablet 200/50 mg every 3 hours. Okay, look, they wait out here, you see, quay quay. Okay. Okay. So this is on medication. And this is a home video of him showing this hyperkinetic movement.
What time of the day is this?
This is in the afternoon.
In the afternoon.
Yeah. So the question would be, this is a clear cut of a patient with Parkinson's disease. My question would be, what's happening on medication?
Nice, quite a nice phenomenology that you demonstrate there. Any volunteer?
Yeah.
คุกกี้อะไรไหม
In this video, I saw chorea in his extremity, upper extremity. I think this consistent with levodopa-induced dyskinesia. And from the video, I saw the contraction of his frontalis, and I don't know, maybe Lobe dystonia. So the diagnosis of this patient may be consistent with maybe you have to think about atypical Parkinsonism So that I think maybe multiple system atrophy or other atypical Parkinsonism.
Okay, very good. 9 years down the line, but she still had very good response to levodopa, and this is clear-cut dyskinesia. The question is, which dyskinesia do you think it is? Is it at the peak of his dose of the medication and levodopa, or is this a diphasic type of dyskinesia that we are dealing with?
I agree with Dr. Puki that this patient developed the choreiform movement and note that the chorea is prominent on the upper body, both arms, and so I think this patient have the peak dose dyskinesia, which is the prominent on the upper side. If it's the diaphasics, it will be prominent on the lower limb, and the phenomenology is kind of be dystonia.
Okay, thank you very much. Yeah, so very rightly mentioned. So in the early time, when the first, what we call as a honeymoon period of Parkinson, maybe the first 3 years or so, most patients, when they take the levodopa, it would last long. It would last probably maybe about 6 hours. They don't develop dyskinesias. Medications, they are very happy. But maybe after 5 years, maybe about around 50% of them started having motor complications. And you can see that the medications become shorter and shorter. They may last maybe about 3 hours, 3+ hours, some even 2 hours, and so. And as time goes by, you tend to also develop dyskinesias and those choric movements that you see over there. And it's estimated about 10% per year after starting levodopa. And the higher risk group would include things like younger age of onset, longer use of levodopa, higher individual doses of levodopa. And because this is more cervical, predominant, truncal, and upper limb, so this is a patient with peak dose dyskinesia. The medication, it's at the levodopa is at its peak. And this is quite a nice diagram from Annals of Neurology showing how we could differentiate based on the phenotype, peak dose dyskinesia versus diphasic dyskinesia, and off dystonia normally at the in the foot. And advanced Parkinson's disease, you may have a bit of mixture of the dystonias of the foot plus the dyskinesias at the orofacial region plus the limbs. And then in MSA, you get the pattern that you see in F here. So this is another home video of his showing a peak dose dyskinesia. You can see the neck is moving on its own, the upper limbs. The first video that you saw, you don't see much of the upper limb because he was holding on the chair very hard. So you don't see a lot of movements, but if he were to let go of the movements on the chair, the upper limbs would be more dominant. So this is the pattern that he's having. So how would you manage wearing off? The first question. So you could, number one, do add-on things like monoamine oxidase inhibitors, such as sertraline, COMT inhibitors, or dopamine agonists. Or you could increase the dosage of the levodopa or shorten the intervals between the levodopa dose. But I guess he's already taking 2-3 hours. Third one, you may want to advise to take the medications before meals. And then there are some studies of eradication of the H. pylori, which would help the absorption of the levodopa. And then lastly, advanced therapies such as DBS, apomorphine, and levodopa, carbidopa infusional gel. How would you manage peak dose dyskinesia? Perhaps decrease the levodopa dose, but a lot of times when you decrease the levodopa dose, then they become off. Without dyskinesia, but they become off. Second, you could discontinue the agents that potentiate the levodopa, for example, the MAOIB inhibitors and COMT inhibitors. You could add in a dopamine agonist, but if that, you may need to reduce the levodopa. You should add in amantadine or then advanced therapies. So peak dose dyskinesia is at this position here. Now we go to another video of his, the same patient. And what is this motor complication? So he complains mainly only at the legs this time, hardly at the hands. And you can see the toes. And this is when the level is much lower without medication. So I would say this is a diphasic dyskinesia, but just keep in mind that diphasic dyskinesia, as you can see in the last diagram here, it can occur just from off, they go into diphasic dyskinesia because of low dose of the levodopa and continue to have diphasic dyskinesia and become off, or they can have an on period and then diphasic dyskinesia and then on and then become off. So there are three ways that can happen here. So in the end, we did bilateral STN DBS for him, which was, I would say, successful. The right side is during programming. Yes. The effect on DBS on the tremor is normally very dramatic, and patients feel very happy with the outcome of that. Okay, so that's my last case.
Thank you very much. Very good cases.
Because we don't have apomorphine infusion in our country, so I would like to ask advantages and disadvantages of apomorphine infusion over the DBS.
Maybe Ron should answer. You use more apomorphine.
Yeah. I would agree that this patient would be better with the deep brain stimulation, really, because the predominant feature is the dyskinesia, different type of dyskinesia. Apomorphine, efficacy on dyskinesia is not very, robust as the deep brain stimulation. Part of it might be related to the dose reduction of the apomorphine, might not be that as much as the deep brain stimulation. So, putting all that together, I think that with the predominant dyskinesia, I would prefer this patient for the deep brain stimulation.
He's also, I think at that time, 48, so he was relatively young, and he wanted to be more independent compared to holding a palm all the way. And cognition was still very good in him.
And with the dyskinesia, which looks quite malignant, to have that with the system, with the pump system, would be a bit difficult. The pump and the needles probably would have a little bit of the technical issues there. Yeah.
Thank you.
Thank you.